Hi everyone, welcome to researchmd.com. We have a great presentation today, Sjogren's syndrome, okay? And all our presentation is going to be like 9 minutes. We understand how valuable time to you. All this will be compressed in 9 minutes. So let's start again. My name is Pramil Cheriyath. I'm a program director in internal medicine, transitional residency, and I teach medical students and residents. I'm also an assistant professor of medicine in 2 major medical schools. Let's look at Sjogren's syndrome. The word autoimmune disorder characterized by exocrine gland dysfunction and dryness of the mucosal surface. That is actually kind of, you hear this term SICA symptoms, the dryness of the mucosal surface. It can occur in the primary, and about 1/3 of the patient have another underlying autoimmune condition. So rheumatoid arthritis is the one thing about autoimmune disease. If you have one autoimmune disease, most likely you could have other autoimmune disorders also. Epidemiology, 0.1 to 4.8%, second most common autoimmune disorder. Overall 0.1 overall prevalence in Europe, and more common in women, usual onset middle age from 40 to 55. There's some epidemiological facts right there. The risk factors: age, usually diagnosed in people older than 40. Sex, women, again, more likely to have. Rheumatic disease is another risk factor. We talked about autoimmune diseases, and you have infectious agent like cytomegalovirus, Epstein-Barr virus, and also, of course, there's genetic involvement also. Anytime you have an autoimmune, there will be some genetic involvement, right? So if you look at there's two pathways we're going to talk about. One is autoimmune pathway, and then we talk about the systemic pathway. Let's look at the autoimmune pathway. You got B lymphocytic dysregulation and hyperactivity, which lead to lymphocytic infiltration of the exocrine glands with a degeneration of the acinar gland, necrosis, atrophy, and decreasing salivary function, okay? Then you have glandular neurodegeneration, damage, and apoptosis of the glandular epithelial cells may be mediated by various pro-inflammatory T helper cells and one type and cytokines. It can cause symptoms. Even 50% of the glandular epithelial cells, even if 50% of the cells intact, you can still have symptoms. Now, what is the systemic pathway? You got the most extragranular manifestation considered expression of the autoimmune epithelialitis, in the vasculitis, or immune complex deposition, and you got complement activation. It can cause skin vasculitis, glomerular nephritis, and peripheral neuropathy. Let's look at the signs and symptoms. We talk about SICA, the dryness. You got usually dry eye, xerothalmia, and dry mouth, xerostomia. Non-specific symptoms: fatigue, sleep disturbances, anxiety, depression, and then you have organ-specific kind of which organs are kind of affected: musculoskeletal, pulmonary, and gastrointestinal symptoms. Okay. So other symptoms, extraglandular manifestation of Sjogren's syndromes are common. You have to look at musculoskeletons, like 90% of them have some kind of musculoskeletal symptom. Constitutional symptoms, we talked about: fever, night sweats, weight loss, gastrointestinal symptoms, swallowing disorder, gastric atrophy, pulmonary manifestation. You can have neurological manifestation, the peripheral nervous system, hematological manifestation, around 20%, malignancy, lymphoma is reported in occur 5 to 7 patients. Always remember that it can cause malignancy, okay? Now, after American College of Rheumatology and European League Against Rheumatism came with their classification criteria, which got 97% sensitivity and specificity 83%. So please use this for your diagnosis. It applies to patients with greater than 1 symptoms at ocular or oral dryness defined as greater than 1, daily persistent troublesome dry eye of greater than 3 months, recurrent sensation of the scent and gravel in eyes, use of tear substitute greater than 3 times a day, daily feeling of dry mouth greater than 3 months, and frequent drinking liquid to aid in swallowing of the dry food because of the dryness. So you got a very good sensitivity and specificity. The scoring, you look at the 3 points for labial salivary gland with the focal lymphocytic sialinitis and focus score greater than 1 foci, and then you got 3 points for positive anti-Sjogren's syndrome antibody or RO, and 1 point for ocular staining score greater than 5, 1 point for Schirmer's test less than 5 per 5 minutes in at least one eye, and 1 point for unstimulated whole saliva flow rate less than 0.1 ml per minute. So patients with a score greater than 4 meet the criteria for primary Sjogren's syndrome. So what are the diagnostic studies you can do? Of course, you can do Schirmer's test to look at the tear function, corneal staining with the colorant like rose Bengal fluorescein to assess the damage to and tear meniscus from the desiccation to conjunctival epithelium. Then you have unstimulated whole salivary flow collection to assess the oral dryness. So let's look at the sensitivity and specificity of Schimmer's test. Sensitivity is only 42%, specificity high, 76%. Then you got corneal staining, sensitivity is 80%, and the specificity is 67%. Okay. Now let's look at the blood test. Always the board question, and always about anti-Rho and anti-Li antibodies, 50 to 70% of the cases. Of course, rheumatoid factor is going to be positive also. ANA is also positive in a lot of patients. So anti-Rho SSA, 42% sensitivity and 100% specificity, okay? And anti-LA SSB sensitivity is 29%, specificity at 99%. So make sure you know this antibodies. Scintigraphy, the salivary gland involved detected by parotid scintigraphy may show delayed uptake, reduced concentration, or delayed excretion of technetium 99 tracer. Got a very good sensitivity and specificity, good test, 85.3% and 77.8% respectively. So SIALOGRAPhy, okay, positive salivary gland involvement detected by SIALOGRAPhy, it will show diffuse sialectasia, that is punctuate or cavitary or destructive pattern without obstruction in the major duct, and the sensitivity for that is around 75% and specificity is like 93%. And then you can do salivary gland biopsy with sensitivity and specificity very high, 86.5 to 97.4, and it's not usually necessary for diagnosis, requires excision of greater than 5 minor salivary glands, and positive biopsy defined as greater than 1 area of dense inflammatory infiltrate with 50 lymphocytes per 4 millimeter squared glandular area. Issues adjacent to the normal mucous tissue. It's good to know what is the biopsy findings also. Now management, there's no known cure for the treatment, mainly like symptomatic and supportive. You can do ocular dryness, you'll consider volume replacement, lubricant, artificial tears, the use of ophthalmic immunosuppressive containing drops such as cyclosporin, autologous serum eye drops, systemic pilocarpine, there's a role for it. Consider punctual occlusions like plugs, cauterization or surgery. Only in severe diseases you can consider this punctual occlusion, plugs, and cauterization. For oral dryness, you can see consider following for you can see the non-pharmacologic stimulant of mild dysfunction, including gestatory stimulants or mechanical stimulants. Pharmacologic stimulation with the muscarinic agonists like pilocarpine or servimeline and moderate dysfunction. You got saliva substitution for like artificial saliva, severe dysfunction, okay? And adequate hydration and good oral hygiene is very, very important. And vitamin D supplementation also has a role in it. Complications, if I remember, one thing always remember, it could cause lymphoma. If I'm writing a question, they will ask you about this. It's extremely high risk. You got like dental caries you can cause, oral candidiasis, sialadenitis, periodontal disease, and then corneal ulceration, eyelid infection. So if I'm writing a question, I always say about the patient coming with the dental caries, dry mouth, and always think about the lymphoma complication. Thank you so much for watching our presentation. We'll be back with another presentation soon. Thank you.